Hello everyone, let's discuss posterior urethral valve, which is also simply called as PUV. It is the most common obstructive urethral lesion in newborns and infants. It is the most common obstructive urethral lesion seen in newborns and infants. First of all, what is posterior urethral valve? Posterior urethral valve is nothing but a fold of urothelium which is causing obstruction in urinary outflow. This is nothing but a membrane of urothelium which has a small slit in it, which is causing various degrees of obstruction of urinary outflow. So these are nothing but mucosal folds or urothelium. Urothelium which is forming a membrane with a small slit in it. Depending upon the diameter of the slit, it will cause mild obstruction, moderate obstruction or severe obstruction. This posterior urethral valve will act like a flap valve. Let's see in a small image how posterior urethral valve will look like. For instance, see this image. So this is bladder, this is prostate, and this is prostate, and this part is prostatic urethra. This is perineal membrane, and the part between that is called membranous urethra. Our posterior urethral valve is most commonly located at distal prostatic urethra. So as you see in the image, this whole thing is prostatic urethra, and in the distal portion we can see this green highlighted part. I have zoomed that image and have drawn it here. So this is prostate, this is prostatic urethra which is lined by urothelium. This green colored one is called urothelium, and there is a fold in distal prostatic urethra. This is called posterior urethral valve. This PUV is most commonly located at distal prostatic urethra, and which is distal to verumontanum. In prostate, we will have verumontanum. Verumontanum is nothing but an area of bulge within the prostatic urethra where seminal vesicles open. Our posterior urethral valve will lie just distal to it. So PUV is located at distal prostatic urethra, just distal to verumontanum. So as I have said, it will act as a flap valve. As you see in this image, this valve is directed upwards. So if urine is coming from the bladder from upwards, it will obstruct the urine. But when we pass the Foley's from below upwards, it will be easy to pass the Foley's. So this is called flap valve. That means patient will find difficulty in micturition, but Foley's can be passed easily. This is exclusively seen in male newborns. So this is exclusively seen in male child, and this is never seen in any female child. Coming to pathogenesis. So let's see this image. On the left side, you will see normal kidneys, normal ureter, and normal trigone, normal prostatic urethra, and normal urethra. So suppose if this patient has PUV, so in the distal prostatic urethra I am mentioning PUV. So the urine can't come out. So this bladder will undergo hypertrophy so that there will be stronger bladder contractions to empty the bladder. But since there is an obstruction it can't empty the bladder. So there will be hypertrophy and dilatation of bladder. As you see in the right hand side, you can see the bladder wall hypertrophied. In severe cases, the bladder may also develop multiple diverticula, which is called bladder trabeculations. So we have seen, because of the obstruction, the prostatic urethra is dilated. And we have seen the distended bladder. And there is bladder hypertrophy, and in severe cases we can also see trabeculations within the bladder. Because of the bladder hypertrophy and the trigone hypertrophy, these ureters can't empty into the bladder properly, which is why they will develop hydrouretronephrosis. As you see in the image, there is tortuous ureter compared to the left one, and the kidney is enlarged compared to the left one. So this is called hydrouretronephrosis, simply HDUN. And because of the HDUN, in long-standing cases, this may lead to renal failure. This is an image taken from Smith serology. As you see in the image, there are dilated and tortuous ureters. And you can see this is hypertrophied bladder. And this part is veromontanum, where you can see the openings of seminal vesicles, and this is our posterior urethral wall. This is our posterior urethral wall, which are direct upwards. So there will be difficulty in downflow of urine. So this is our posterior urethral wall, and this is veromontanum. As you see in the image, you can see that bladder is distended, and the prostatic urethra is also distended. Coming to clinical presentation of the baby, in most of the cases, the failure to thrive is the only presenting symptom. The baby can't gain weight. It might be the only presenting symptom in most of the cases. But he can also present with, since the baby can't empty the urine properly, there will be urinary stasis, and this urine might get infected. This will cause urinary sepsis and recurrent urinary tract infections. And this toddler or baby will have difficulty in passing urine. In cases of severe obstruction due to PUE, as we have discussed already, there will be hydrouretronephrosis, which is so severe that it can be presented as abdominal mass. That severe obstruction will lead to severe HDUN, which might be unilateral or bilateral, and this might be presenting as abdominal mass. Coming to investigations, we might need to send a complete urine examination, and we might find pus cells, because most of the times the urine is infected, and we need to send blood urea nitrogen and serum creatinine to evaluate the renal function, because as we know, in 30% of patients of PUV, there will be renal dysfunction. You will find renal failure. So it is mandatory to send a renal function test, that is creatinine and blood urea nitrogen, to check the renal function. And best investigation to diagnose posterior urethral valve is micturating cystourethrogram. Micturating cystourethrogram. This is an image of micturating cystourethrogram showing this is the distended bladder, and this is distended prostatic urethra. So in creatine cystourethrogram, you will find distended bladder and distended prostatic urethra. And if there is associated vesicoureteric reflex, you will also find vesicoureteric reflex in creatine cystourethrogram. It is difficult to see these posterior urethral walls on urethroscopy, because if this is urethra and this is our scope and this is our cystoscope and these are our walls. During urethroscopy, we will inject some irrigant, which will lead to opening of these flap walls into open direction. So when this urethroscope will press some irrigant fluid, this valve will open like this, and you might see a normal urethra, and most of the times this PUV can't be seen properly with urethroscope. So the best investigation to diagnose posterior urethral valve is by penetrating cystourethrogram. So diagnosis can be done at 2 stages. One, it can be done as early as 28 weeks of gestation. On antenatal ultrasound. So your antenatal ultrasound will show distended bladder and distended prostatic urethra, and you should suspect PUV in such cases. In severe cases, there will be associated pulmonary hypoplasia and oligohydramnios in such cases. In a child, the diagnosis is confirmed by MCUG, that is micturating cystourethrogram. Coming to management, the first initial management we should do is catheterization. If you pass the Foley's catheter, first thing, it will be very easy, because the valves are directed in upward direction, so it will be very easy to pass the Foley's from below upwards. So after passing Foley's, you will find a lot of urine coming out. So we need to do catheterization as the first step to decompress the bladder. For mild to moderate cases, where PUV is causing mild to moderate obstruction for urinary outflow, we should do endoscopic fulguration of the walls. Endoscopic fulguration of walls. See, as you see, we'll pass the endoscope via urethra, and we'll cut these urethral walls. And it is so easy with endoscope. In case of severe obstruction, we might need to do loop ureterostomy. In severe cases, there will be renal dysfunction. So it is very essential to divert the urine out, and the bladder might also be dysfunctional. So we should brought the ureters out onto the skin. This is called as loop ureterostomy. This is simply shown in this figure. See, as you see, this is the skin, and this is kidney, and this is ureter, and this is bladder. And this ureter is brought out as a loop, as shown in the figure, and will make an opening in the ureter. So the urine will come from kidney and will be diverted out. This is called loop ureterostomy. And in severe obstruction, we might need to do loop ureterostomy, and when the renal function improves, and we will reconstruct the urinary tract. Coming to prognosis, 50% of the patients of a PUV will have vesicoureteric reflex. If this is bilateral, the prognosis will be poor. Presence of PUR will lead to renal dysfunction in the long term, and this will lead to failure of kidneys. and 30% of the patients will land into renal failure. So the only way is early diagnosis and prompt treatment. It is the only way to save the kidneys of this patient. Thank you.